Hello, everybody. I wish to thank the organizers for inviting me in this meeting, and I will use these 15 minutes roughly to provide you with an update on the use of ambulatory blood pressure monitoring in 2023. We know that office pressure started in Italy in 1896, and in 2023, little has changed. And the guidelines still propose office pressure as a backbone for hypertension diagnosis and management. Although we are aware of many limitations, errors in the technique, variability in blood pressure, which cannot be managed using isolated office readings, the Y-code phenomenon, and the masked hypertension phenomenon, the hypertension occurring outside the office. Definitely, ambulatory blood pressure monitoring can give us some solution. You can have a profile, as you can see. You can have different readings during the day and the night, combined with heart rate, and you may identify different possible behaviors of blood pressure, which cannot be easily managed just using isolated office readings. Over the years, technology has been improved. You may remember that the first few devices were quite bulky, noisy, not well accepted by patients. And you can see these ladies were wearing dresses of the 60s. Now we have smaller devices, easier and lighter, and much less noisy. And we can pick up the Y-code phenomenon, as you can see here, with the ABPM, including the hours spent in the clinic when the device is set on the patient. We may identify, even in hypertensive patients, the occurrence of a dipping at night. And we may also pick up a reverse phenomenon when blood pressure is increasing at night, as in case of patients with obstructive sleep apnea, as in this case. If you combine office and out-of-office blood pressure, in particular ambulatory blood pressure, then, as you know very well, we can identify for different phenotypes the real normotency, where everything is normal, the sustained hypertension when both pressure are elevated, and the situations where you have a discrepancy, only office elevation, the Y-code hypertension, or only out-of-office blood pressure elevation, the so-called masked hypertension. And ABPM, as you know, as an important prognostic value. Office pressure is predicting outcome, as you can see in this study, the SISTIO study, quite old, but we had a placebo group at that time, which allowed us to identify the impact of blood pressure on events. Daytime pressure was a better predictor, 24-hour even better, but the best was nocturnal blood pressure, that you can measure only by using ambulatory blood pressure monitoring quite efficiently. And even when you measure blood pressure variability, that was the first study probably ever demonstrating that for any given mean pressure level, if you have a higher blood pressure variability, the red bars, you have more organ damage, independent from the level of blood pressure. You can also identify the different behaviors of blood pressure changes induced by treatment. For example, here you see a case of a patient taking a short-lasting drug where blood pressure is going down even too much for a few hours only, and then the patient is not controlled. That's an example of masked uncontrolled hypertension due to an erroneous selection of a drug. And you can see the reverse also, as in this case, when you are treated with a long-lasting combination treatment, you might have a smooth reduction of blood pressure all over the 24 hours. So these are the benefits that ambulatory blood pressure monitoring can provide us with. But there is some new evidence showing that even when you pick up hypotension, you might identify a risky condition. In this paper we published recently, we found that whenever you identify just 1 or 2 episodes of daytime systolic pressure lower than 90 or 100, you might have a much higher risk of syncope. And this was published in the European Heart Journal last year. So ABPM can give us a lot of information. What are the guidelines telling us? You may remember 2021, we published this paper with George Teggio and our working group of ESH on how to measure blood pressure in different settings. And there was a session devoted to ambulatory blood pressure monitoring. The advantages we're highlighting were the possibility to get an objective assessment of blood pressure over the 24 hours, identifying white-coat and masked hypertension, confirming uncontrolled hypertension and resistant hypertension, and getting information on blood pressure during the usual daily activities. You can also detect nocturnal hypertension and non-dipping phenomenon, and also, as I've shown just before, the possibility of an excessive blood pressure lowering by drug, which may be a risk for syncope. The limitations are that ABPM is not always available in a primary care setting. It's quite expensive in many countries and time-consuming for the healthcare provider. Many patients don't like it because it might cause discomfort, mainly during sleep, and they don't want to repeat it too many times. There is also an imperfect reproducibility of the diagnosis, although the reproducibility is better than the measurement obtained in the office. And sometimes you may make mistakes in calculating a sleep blood pressure because you don't calculate exactly the sleeping times of a given individual. What are the clinical indications according to this paper, 2021? To diagnose hypertension, to detect white-coat and masked hypertension, to identify nocturnal hypertension and non-dipping, and also to assess an increase in blood pressure variability as in the case of autonomic failure. You might also get indication for treated patients. You can identify the so-called white-coat resistant or masked uncontrolled hypertensive. You can confirm the diagnosis of uncontrolled and resistant hypertension. You can, as I've showed you before with the two examples, detect whether you achieve or not a smooth 24-hour blood pressure control, which is particularly important in the high-risk patients. You can confirm hypotension due to excessive treatment, and again, analyze behavior of nocturnal blood pressure under treatment. And you can also double-check the cases of disagreement between office and home blood pressure measures. In particular cases, you need to repeat it, mainly in high-risk patients. This depends on the availability and on the level of risk, and also sometimes on the preference. In uncontrolled hypertension, we recommend to perform another recording after 2-3 months until you normalize the profile. While in control patient, you might do an ABPM every 12 months, mainly in the same days, possibly working days. The threshold for diagnosing hypertension in this paper remained those of the previous guidelines, 130/80 for 24-hour average pressure, 135/85 for daytime hypertension, 120/70 for nighttime hypertension. And a dipping phenomenon is when you have a reduction in blood pressure at night equal or greater than 10% of daytime values. As this been translated into the recent ESH guidelines, I just want to spend a few minutes with you going quickly through what the ESH guidelines tell us now on the use of ABPM. That's the most recent update we have only a few months ago. Well, they definitely recommend ABPM in addition to office pressure to improve risk prediction. They recommend this to identify white-coat and masked hypertension and nocturnal blood pressure phenotypes, and they also insist for the use of ABPM to diagnose true resistant hypertension. They recommend using upper arm cuff automated devices validated, and the Strike BP website can tell you what are the devices validated, and with a frequency of measurement every 20 minutes. These are the conditions where ABPM is recommended by the guidelines. Atherosclerotic renovascular disease, where you might find resistant hypertension and non- or reverse dipping. Fibromuscular dysplasia, again, you might have 24-hour increase in pressure very early, or resistant hypertension. Primary aldosteronism, where you might find true resistant hypertension and non-dipping or reverse dipping. Pheochromocytomas and paragangliomas, again, where you can find non-dipping at night, but also an increase in blood pressure variability. The Cushing syndrome, where again there is an increase in short-term variability and non-dipping phenomenon. Then you have conditions such as the true resistant hypertension that you have to identify whenever you see a persistently high office pressure on treatment to avoid the confounding of white-coat resistant hypertension. White-coat hypertension is definitely one of the conditions where out-of-office blood pressure is recommended, and they also recommend to repeat ABPM several times to confirm the reproducibility of this phenomenon. The same applies to masked hypertension. because that's a situation occurring outside the office, and you can only diagnose it if you are measuring blood pressure in those conditions. Nighttime hypertension and nocturnal blood pressure phenotypes are another indication, as also said in our previous position paper, and this is confirmed in these guidelines. And I also recommend ABPM in children and adolescents because you can learn a lot about blood pressure behavior in daily life activities in these young people. It is also recommended in diabetes because there is a high frequency of non-dipping in diabetes that has to be identified. The same applies to CKD, where non-dipping or elevated nighttime pressure is a frequent finding and may be effective on prognosis. In glaucoma, you might have also high blood pressure associated, and ABPM is important to identify the nocturnal behavior of blood pressure, also in case of hypotension, which might damage the optic nerve. In cancer patients, it is also recommended because this might help us identifying blood pressure changes due to anti-cancer drugs. And finally, in the follow-up. The follow-up ABPM is recommended because this might help you monitoring how well you are controlling blood pressure in daily life. So you see the very recent guidelines are recommending and reinforcing all the indications given by our previous position papers and are insisting more than before on the use of this important tool. A final point, may we use cuffless devices for 24-hour ABPM in our time? In this position paper we published last year, you can find the answer. We have several possibilities of methods for measuring blood pressure with the cuffless technology, using pulse transit time, pulse wave analysis, facial video processing, oscillometry, finger pressing, ultrasound, volume control. But as we are showing clearly in this paper, although we have a lot of promises, the technology is quite exciting, and it might give us information on blood pressure changes very quickly occurring during the day and night, and maybe predicting the risk of complication better. But they are sold out for financial reasons. There is no evidence of their benefit. We have no information of their accuracy or on whether they might result in an improved outcome. So we have to wait for adequate validation of these devices before using them. So take-home messages. Blood pressure should be measured repeatedly over time in different visits. This is still an important recommendation. It should be measured accurately. We need repeated office reading, this for everyone. But then we have to use more widely out-of-office blood pressure monitoring. Home blood pressure is important, 3-7 days before a visit in long-term follow-up, but 24-hour ABPM is essential to confirm the diagnosis, to detect white coat and mass hypertension better, and to monitor BP control in daily life. Mainly when you focus on nocturnal blood pressure, it is mandatory in clinical trials. Concerning wearables, more investigation is still needed. They are very interesting devices. The technology is quite promising, but is still immature at our time for a clinical application. So the question is, given all these advantages of ABPM, should we now start anyway taking decision on how to treat our patient based on out-of-office pressure? Well, we have some indication, but there is no intervention trial available. That's why we are now running the master study. Some of you were asked to participate, and this study is ongoing, and we might be able to give you some more indication shortly on the possible usefulness of ABPM. Thank you for your attention. I just want to conclude that if hypertension remains a stealth killer, we might improve its management by using a better blood pressure monitoring, including ABPM. If you need more information, that's my email. You are welcome to contact me anytime. Thank you again for your patience and for your invitation.